Hi everyone, welcome to module 8.2.2. In this, we're going to highlight some of the cranial nerves. So let's get started. The cranial nerves are PNS components that connect directly to the brain, and the 12 pairs of cranial nerves are visible on the ventral side of the brain. Each has a name related to its distribution or its function. So the number that's assigned to a cranial nerve corresponds to the nerve's position on the longitudinal axis of the brain, beginning at the cerebrum. Roman numerals preceded by the letter N are usually used, and you may sometimes encounter these numerals preceded by the letter CN. Each cranial nerve attaches to the brain near the associated sensory or motor nuclei, and the sensory nuclei act as switching centers, with the postsynaptic neurons relaying the information to other nuclei or processing centers in the cerebral or cerebellar cortex. In a similar way, the motor nuclei receives convergent inputs from higher centers to form other nuclei along the brainstem. So in this module, we classify cranial nerves as primarily sensory, special sensory, motor, or mixed, being sensory and motor. And in this classification, sensory nerves carry somatic sensory information, including touch, pressure, vibration, temperature, or pain. And special sensory nerves carry the sensations of smell, sight, hearing, or balance. Motor nerves are dominated by the axons of somatic motor neurons. Mixed nerves have a mixture of sensory and motor fibers. This classification scheme is useful, but it's based on the primary function, and a cranial nerve can have important secondary functions as well. Three examples worth noting are 1, the olfactory receptors, the visual receptors, and the receptors of the internal ear are innervated by cranial nerves that are dedicated almost entirely to carrying special sensory information. In contrast, the sensation of taste, considered to be one of the special senses, is carried by axons that form only small parts of large cranial nerves that have other primary functions. And 2, as elsewhere in the PNS, a nerve containing tens of thousands of motor fibers that lead to a skeletal muscle also contains sensory fibers from muscle spindles and Golgi tendon organs in that muscle. And we assume that these sensory fibers are present but ignore them in classifying the nerve. And finally, 3, regardless of their functions, several cranial nerves, the third, the seventh, the ninth, and the 10th, distribute autonomic fibers to peripheral ganglia, just as spinal nerves deliver them to ganglia along the spinal cord. We'll note the presence of small numbers of autonomic fibers, but ignore them in classification of the nerve. Cranial nerves are almost always clinically important, in part because they can provide clues to underlying CNS problems, and clinicians assess the cranial nerve function with a number of standardized tests. And two useful mnemonics for remembering some of these cranial nerves, and in order, are OOO, to touch and feel very green vegetables, heaven, and O, once one takes the anatomy final, very good vacations are heavenly. I'm more privy to the second one, but each is an option for you to help remember some of the cranial nerves. The olfactory nerve, or nerve number 1, the first pair of cranial nerves carry special sensory information responsible for the sense of smell. The olfactory receptors are specialized neurons in the epithelium covering the roof of the nasal cavity and the superior nasal concha and the superior parts of the nasal septum. Axons from these sensory neurons collect to form 20 or more bundles that penetrate the cribriform plate of the ethmoid bone, and these bundles are components of the olfactory nerves. Almost at once, these bundles enter the olfactory bulbs, neuromasses on either side of the cystic gallery. The olfactory afferent synapse within the olfactory bulbs, and the axons of the postsynaptic nerves proceed to the cerebrum along the slender olfactory tracts. And because the olfactory tracts look like typical peripheral nerves, anatomists about a century ago misidentified these tracts as the first cranial nerves. Later studies demonstrated that the olfactory tracts and the bulbs are part of the cerebrum, but by then the numbering system had already been firmly established. Anatomists were left with a forest of tiny olfactory nerve bundles lumped together as cranial nerve 1. The olfactory nerves are the only cranial nerves attached directly to the cerebrum, and the rest originate or terminate within the nuclei of the diencephalon or the brainstem, and the ascending sensory information synapses in the thalamus before reaching the cerebrum. The optic nerves, or nerve 2, carry visual information from the special sensory ganglia into the eyes, and these nerves contain about 1 million sensory fibers. The optic nerve pass through the optic canals of the sphenoid and then converge at the ventral anterior margins of the diencephalon at the optic chiasm. At the optic chiasm, fibers from the medial half of each retina cross over to the opposite side of the brain, and the recognized axon continued toward the lateral denticulate nuclei of the thalamus of the optic tracts. After synapse in the lateral denticulates, projection fibers deliver the information to the visual cortex of the occipital lobes. And with this arrangement, each cerebral hemisphere receives visual information from the lateral half of the retina of the eye, and on that side from the medial half of the retina of the eye from the opposite side. A few axons in the optical tracts bypass the lateral genticulate nuclei and synapse in the superior colliculi of the brain. The oculomotor nerves. The midbrain contains the motor nuclei controlling the third and fourth cranial nerves. Each of the oculomotor nerves, or nerve 3, innervates 4 of the 6 extrinsic muscles that move the eye and the levator palabre superioris muscle, which raises the upper eyelid. On each side of the brain, cranial nerve 3 emerges from the ventral surface of the midbrain and penetrates the posterior wall of the orbit of the superior orbital fissure. Individuals with damage to this nerve often complain of pain over the eye, droopy eyelids, and double vision because the movements of the left and right eyes cannot be coordinated properly. The oculomotor nerve also delivers preganglionic autonomic fibers to neurons of the ciliary ganglia. These neurons control intrinsic eye muscles, and these muscles change the diameter of the pupil, adjusting for the amount of light that enters the eye. They also change the shape of the lens to focus images on the retina. Moving on to the trochlear nerves. So a trochlear nerve, or nerve 4, the smallest cranial nerve, innervates the superior oblique muscle of each eye. The trochlea, or a pulley-shaped ligamentous sling, each superior oblique muscle passes through a trochlea on its way to insertion in the surface of the eye. An individual with damage to the cranial nerve 4 or to its nucleus had difficulty looking down into the side. And finally, on this side, the abducens nerves, or nerve 6, and the abducens nerves innervate the lateral rectus muscle and the 6 pair of extrinsic eye muscles. Contraction of the lateral rectus muscle makes the eye look to the side. So in essence, the abducens cause abduction of the eye. Each abducens nerve emerges from the inferior surface of the brainstem at the border between the pons and the medulla oblongata. Along with the oculomotor and trochlear nerves from that side, it reaches the orbit through the superior orbital fissure. So the pons contains the nuclei associated with 3 cranial nerves, nerve 5, nerve 6, and nerve 7, and contributes to a 4th nerve, the 8th. The trigeminal nerves, or the largest cranial nerves, are mixed nerves. Each provides both somatic and sensory information from the head and the face, and the motor control over the muscles of mastication. Sensory, or dorsal, and motor ventral roots originate from the lateral surface of the pons. The sensory branch is larger, and the enormous semilunar ganglion contains the cell bodies of the sensory neurons. As the name implies, the trigeminal has 3 major branches. The small motor root contributes to only one of these 3. The tic douloureux, or the trigeminal neuroganglia, or neuralgia, is a painful condition that affects the area innervated by the maxillary and the mandibular branches of the trigeminal nerve. Sufferers complain of debilitating pain triggered by contact with the lip, the tongue, or the gums. The cause of this condition is unknown, but the trigeminal nerve branches are associated with the ciliary, the sphenopalatine, the submandibular, and the octic ganglia. And these are autonomic or parasympathetic ganglia whose nerves innervate structures of the face. And although these nerve fibers may pass around through the ganglia, the trigeminal nerve does not contain visceral motor fibers. The facial nerves, or nerve 7, are mixed nerves. The cell bodies of sensory neurons are located in the genticulate ganglia, and the motor nuclei are in the pons. On each side of the sensory and motor roots emerge from the pons and enter the internal acoustic medius of the temporal bone. Each facial nerve then passes through the facial canal to reach to the face by way of the stylomastoid foramen. The nerve then splits to form the temporal, zygomatic buccal, mandibular, and the cervical branches. The sensory neurons monitor proteoreceptors in the facial nerves and provide deep pressure sensations over the face. They also receive taste information from the receptors along the anterior 2/3 of the tongue. Somatic motor fibers control the superficial muscles of the scalp and the face and deep muscles near the ear. The facial nerves carry preganglionic autonomic fibers to the pterogallopine and the submandibular ganglia. Postganglionic fibers through the pterygolepine ganglia innervate the lacrimal glands and the small glands in the nasal cavity and the pharynx. The submandibular ganglia innervate the submandibular and sublingual salivary glands. Bell's palsy is a cranial nerve disorder that results from an inflammation of a facial nerve. The condition is probably due to a viral infection, and signs and symptoms include paralysis of the facial muscles on the affected side and the loss of taste sensation from the anterior two-thirds of the tongue. The condition is usually painless, but in most cases, the symptoms fade after a few weeks or a few months. The vestibulocochlear nerves are also known as the acoustic nerves, the auditory nerves, and the statoacoustic nerves. And we use the term vestibulocochlear because the term indicates the names of the two major branches, the vestibular branch and the cochlear branch. Each vestibulocochlear nerve lies posterior to the origin of the facial nerve, straddling the boundary between the pons and the medulla oblongata. This nerve reaches the sensory receptors of the internal ear by entering the internal acoustic medius in company with the facial nerve. Each vestibulocochlear nerve has two distinct bundles of sensory fibers, and the vestibular branch originates at the receptors of the vestibulae and the portion of the internal ear concerned with balance and sensation. The sensory neurons are located in the adjacent sensory ganglion, and their axons target the vestibular nuclei of the pons and the medulla oblongata. These afferent convey information about the orientation and the movement of the head. The cochlear branch monitors the receptors in the cochlea, the portions of the internal ear that provide the sense of hearing, and the cell bodies of the sensory neuron that are located within a peripheral ganglia, and their axon synapse within the cochlear nuclei of the pons and medulla oblongata. Axons leaving the vestibular and cochlear nuclei relay sensory information to other centers or innate reflexes and motor responses. So the medulla oblongata contains the sensory and motor nuclei of the cranial nerves 9, 10, 11, and 12, in addition to the vestibular nerves of nerve 8. So the glossopharyngeal nerves, or nerves 9, innervate the tongue and the pharynx, and each glossopharyngeal nerve penetrates the cranium within the jugular foramen with cranial nerves 10 and 11. The glossopharyngeal nerves are mixed nerves, but sensory fibers are most abundant. The sensory nerves on each side are in the superior or the jugular ganglion and the inferior or the pectoral ganglion. The sensory fibers carry general sensory information from the lining of the pharynx and the soft palate to a nucleus in the medulla oblongata. And these nerves provide the taste sensations from the posterior third of the tongue. Additionally, they have special receptors that monitor the blood pressure and the dissolved gas concentration in the carotid arteries, which are the major blood vessels in the neck. The somatic motor fibers control the pharyngeal muscles involved in swallowing, and visceromotor fibers synapse in the otic ganglion. The postganglionic fibers innervate the parotid salivary gland of the cheek. So one of the more important ones, the ones you'll hear more often, is the vagus nerves, and those arise immediately posterior to the attachment of the glossopharyngeal nerves. Many small rootlets contribute to their formation. Developmental studies indicate that these nerves probably represent the fusion of several smaller cranial nerves during our evolutionary history. Vagus means wandering, and the vagus nerve branches and radiates extensively. Sensory neurons are located in the superior or the jugular ganglion and the inferior or the nodos ganglion. Each vagus nerve provides somatic sensory information about the external acoustic medius in the diaphragm and special sensory information from the pharyngeal taste receptors. But most of the vagal afferents carry visceral sensory information from receptors along the esophagus, respiratory tract, and the abdominal viscera, as distant at the last portion of the large intestine. This visceral sensory information is vital to the autonomic control of visceral function. The motor components of the vagus are equally diverse. Each vagus nerve carries preganglionic autonomic or parasympathetic fibers that affect the heart and control smooth muscles and glands within the areas monitored by its sensory fibers, including the stomach, the intestines, and the gallbladder. Difficulty in swallowing is one of the most common signs of damage to either nerve 9 or nerve 10. And damage to either one prevents the coordination of the swallowing reflex. The accessory nerves, or nerve 11, are also known as the spinal accessory nerves, or the spinal accessory nerves. Unlike other cranial nerves, each accessory nerve has some motor fibers that originate in the lateral part of the anterior grain horns of the first 5 cervical segments of the spinal cord. These somatic nerve fibers form the spinal root of nerve 11, and they enter the cranium through the foramen magnum and then join the motor fibers of the cranial root, which originate at a nucleus in the medulla oblongata. The opposite nerve leaves the cranium through the jugular foramen and divides into 2 branches. The internal branch of nerve 11 joins the vagus nerve and innervates the voluntary swallowing muscles of the soft palate, the pharynx, and the intrinsic muscles that control the vocal cords. The external branch of nerve 11 controls the sternocleidomastoid and trapezius muscles of the neck and back. The motor fibers in this branch originate in the lateral gray part of the anterior horns of the cervical spinal nerves from C1 to C5. Each hypoglossal nerve leaves the cranium through the hypoglossal canal, and the nerve curves to reach the skeletal muscles of the tongue. And this cranial nerve provides the voluntary motor control over movements of the tongue. This condition is checked by having you stick out your tongue. And damage to one of the hypoglossal nerves is associated nuclei that causes the tongue to veer towards the affected side, whichever that may be. And this is just a table showing what we've just talked about so far. So cranial nerve reflexes are autonomic responses to stimuli that involve the sensory and motor fibers of the cranial nerves. They include both monosynaptic and polysynaptic reflex arts. And these reflexes are clinically important because they provide a quick and easy method for observing the condition of cranial nerves and the specific nuclei in the tracts in the brain. The somatic reflexes mediated by the cranial nerves are seldom more complex than the somatic reflexes of the spinal cord. These cranial reflexes are often used to check damage to the cranial nerves or the associated processing centers of the brain. The brainstem contains many reflex centers that control visceral motor activity. The motor output of these reflexes is distributed by the autonomic nervous system. As we'll see later on, the cranial nerves carry most of the commands issued by the parasympathetic division of the ANS. Spinal nerves T1 through L2 carry the sympathetic commands. And many of the centers that coordinate autonomic reflexes are located in the medulla oblongata. These centers can direct very complex visceral motor responses that are essential to the control of respiratory, digestive, and cardiovascular functions.